What's up, what? What's up, what? What's up, what? अभी तो व्हाट्सएप में फोटो किधर है? ज्ञानेंद्र सर है।
आगे से है। हेलो। अभिषेक सर, हेलो, अभिषेक सर।
हेलो, हाँ बोलिए, क्या हुआ?
हाँ सर, मतलब इको तो नहीं आ रहा है ना वॉइस में?
नहीं, इको नहीं आ रहा, ठीक है।
ओके, थैंक यू।
या
Good evening, all.
Good evening. We are just waiting 1 or 2, 3 minutes. Dr. Sharma is Dr. GR Sharma join.
Talking to GRS.
Hi. But now my student has to join.
सर आपका आवाज बहुत कम आ रहा है.
Can you hear me?
Yes, sir.
आपका आवाज बहुत कम आ रहा है सर.
अभी भी कम आ रहा है?
नहीं आवाज बहुत कम है.
नहीं सर, ऑडिबल है, परफेक्ट है.
Okay, fine. I'm just waiting for my students to start. I think they are held up. I'll just find out.
He is joining. Swapnil is joining, sir. Swastik is joining, sir.
Swastik join किया? Well, good.
He joined. Rakesh bhai, please make him host. Swastik.
Sir, am I visible to everyone?
Yes.
Yeah,
yes,
you're
sir.
visible. We just wait for 2 to 3 minutes.
Okay, sir.
Swastik, who all are answering, please mention the names.
हाँ sir. Yes, sir. Today, Dr. Ajinkya sir, Dr. Miraj ma'am, and Dr. Achin sir will be answering.
Yeah, बोलो. No, GR Sharma, can we start now?
सर, आप जब भी डिसाइड करें.
Yeah. Okay. So who are three answering?
Sir, Dr. Ajinkya sir, Dr. Achin sir, and Miraj ma'am.
Okay. Fine. So start. Swastik.
Yes, sir. So coming to the first case, good evening, all the faculty members and seniors. So 19-year male presented with complaints of bilateral flank pain, right more than left for 15 days, and fever off and on for 10 days.
Dr. Gite is saying there is no sound, but we can hear it. Dr. Gite, I think something is wrong with your Rakesh. Can you explain him? He can again join.
सर लॉग आउट होके वापस ज्वाइन कर सकते सर वो तो आ
Sir,
जाएगा
just check if your left side on top speaker is not muted.
अच्छा खासा लाइफस्टाइल कर रहा है, सब अपना महंगा महंगा गाड़ी ले रहा है.
Gite sir, check if your mic is not muted on the left side on top.
Not muted, sir. Not muted.
Okay, sir. Okay.
Can you hear it? Can you hear us now?
Very low sound, sir. Okay,
you can
I
log out
will
and
try to
re-log in.
rejoin. No problem.
Yes, yes.
If you have got a headphone, use it. Then it will be proper. Because mic might be, affected, but a headphone will be, you'll be able to hear it clear. Okay. Fine, start.
Good evening, everyone. A 19-year male presented with complaints of bilateral flank pain, right more than left for 15 days, and fever off and on for 10 days.
Fine. So, Achin, let us start with you. When does when you're sitting in OPD and such a patient comes to you, what are the differential diagnoses that comes to your mind? So, he's a 19-year-old male, both the loin pain and has got a fever.
Based on only on the chief complaints, first differential diagnosis will be urolithiasis. Then, sir, bilateral flank pain.
Achint, please speak loudly. Speak loudly, Achint.
Can you hear me now?
Yes.
The first diagnosis will be urolithiasis. It could be bilateral obstruction, ureteric calculus, or a bladder calculus, or a urethral calculus. Then, sir, any cystic diseases of the kidney, which could be bulky and any infected cyst. Then, sir,
At 19, will PUG be more common or cyst will be more common?
PUJ more. It's bilateral. It could be both, sir. PUJ more than cyst.
See, at 19, PUJ may be more common, but bilateral, if you go to see, then even a cystic lesion can be, because it is bilateral. And then
Yes.
all the congenital anomalies.
Yes, sir. Congenital anomalies could be PUJ, it could be congenital megaureter, it could be vesico-ureteric obstruction, it could be high bladder neck, it could be posterior urethral wall, and then last diagnosis could be GUTB, sir. Both plain and fever.
Gaurang sir.
Yeah.
Yeah. Can I add something?
Please.
Yeah, Achint.
You are the main.
Yeah.
You are the
so
main.
Achint, when somebody has come to you in the OPD, he has not diagnosed himself as having urological problem. And there is no rule in the world which says that a patient who walks into you will have a urological problem only. So your first approach, don't try to think in those terms. It will be a urological problem always. What is the character of the pain? What is the site of the pain? And all the characteristics of the pain should be clearly elaborated. You should ask questions to elaborate and know in detail about it, and then ask about fever also. See, it is not necessary that he should have only a urological problem. It could be a non-urological problem.
Just based on the complaints I was telling, sir, history of presenting illness, you have to ask for many things.
No.
To elaborate.
Achint, I am totally agree with sir. whenever the patient had a bilateral pain, so whatever the diagnosis you have enlisted, that should be, patient should have bilateral pathology or infravesical pathology. If it is a supravesical, it should be bilateral. And if it is infravesical, then it may be anything. It may be stricture, it may be VOR, it may be bilateral ureteric stone, it may be bilateral PUJ. How come bladder stone will cause bilateral pain? Then that stone probably should be very large and compressing both bilateral ureteric opening. Probably very rarely that can be possible. So while telling the differential diagnosis, before telling the differential diagnosis, what sir told, it is very necessary to elaborate the chief complaint.
Yes.
And if that where is the pain? Is it radiating? Is it intermittent, regular, severe, diffuse, pinpointing, colicky, associated fever, associated any other lower urinary tract symptoms, associated hematuria? ऐसा वो पूरा वो symptoms को पूरा one go में पूरा clear करना है.
And it becomes very important when you are practicing as a urologist, because very often you will come across patients who will come with an ultrasound report which mentions 4 mm, 5 mm stones in the calyces, and they attribute all these symptoms to the pain. But if you are diligent enough to elicit a proper history, you will find the right cause of the pain and treat him rather than treating his report.
Yes.
Yeah.
Yeah, so Achin, go ahead.
So, sir, we have to elaborate the chief complaint first. I would like to know a little more history about pain. I would like to know about the site, onset, character, radiation, and aggravating and relieving factors. And I would like to elaborate fever also in terms of how much grade it is, whether it is continuous or intermittent, and whether it's associated with the evening rise of temperature, whether it's associated with chills, and sir, other negative history.
So negative history, you tell us, or Ajinkya can tell us. Ajinkya, what are the negative history you like to ask?
So I like to, other than this ODP, I like to elaborate, like if the patient had any history of associated with fever, that patient have any history of hematuria, lithuria, pyuria, any history of any stone disease in the past. Is there any history of any instrumentation in the past? Then I'll also like to know whether the patient has any bilateral pedal edema, facial puffiness, in order to rule out any renal function loss. Any also history of any past medication he's on regularly is taking. Then also in case of also like to have the childhood history, sir. If patient if patient or the patient relatives are along with him.
Miraj wants to add anything? Miraj?
I want to know if this patient is diabetic, he's having any low back pain, any radiation to the legs, and any vomitings associated, and if the fever is associated with chills, and
History of low urinary tract symptoms.
yes, sir. Any history of obstructive voiding?
Okay, fine.
And dysuria and
okay, Swastik, go ahead.
Yes, sir. Yes, sir. The pain was located at the bilateral flanks. It was gradually progressing, dull, aching, non-radiating. There was no aggravating or relieving factors. Sir. Fever was associated with chills. It was high grade and was relieved with medications. Sir. Coming to negative history, there was no history of dysuria, hematuria, or lithuria. There was no history of facial lower limb swelling, no history of backache. Coming to past medical history, no history of hospitalization in the past, no significant medical history. History of query PV fulguration at 7 years of age, there was no documentation available. And history of bladder neck incision 4 months back. Coming to pregnancy and birth history, Normal maternal history during the pregnancy. It was a complete term. There was no history of oligohydramnios. Labor was normal. Normal vaginal delivery was there. No instrumentation. And coming to neonatal history, patient was had a normal Apgar at birth. No NICU admission, no hospitalization was there. Perinatal scans were not available with the patient, sir. All milestones were reached normally. Patient was completely immunized. Presently, he was pursuing schooling, and there is no history of enuresis, temper tantrums, pica, thumb sucking, etc. during the development. He was breastfed till 1.5 years. His normal feedings were started and tolerated. Normal weight gain pattern was there. There was no headache, no history of headaches, unconsciousness, ENT infections or tonsillitis. There was no history of cyanosis or dyspnea. No history of frequency, dysuria, hematuria, discharge, abdominal pains or polyuria previously, as mentioned, sir. There was nothing contributory from the family history, sir.
So any one of you want to ask anything? Or we'll ask
No
Dr.
previous ultrasounds, antenatal ultrasounds or
No, it is
postnatal.
not available.
He is available.
So we
Was
are
he on
presuming,
any chemoprophylaxis or
Operative notes
something?
finding.
so we are presuming
Uh,
that either it was not done because many a times they do only fetal ultrasonography. They don't do maternal ultrasonography at many places. So either that or it was not done or they have not kept the record or it was normal.
So 4 months
So
ago,
you
was he
should
having similar complaints
interested
in
in
past?
asking more about the interventions, because patient had a bilateral loin pain and patient had a history of PU wall fulguration. So one of the commonest problem associated with PU fulguration is post-fulguration stricture. Okay, that should be reflected clinically with lower urinary tract symptoms of voiding type. So that is one problem. So why the fulguration is too late? So at the age of 7 years. So what is the presentation at that time? Is it a shuttle wall? It is this that wall is associated with complication? ये सब चीजें पॉसिबल है तो डिटेल डिग आउट करना जरूरी है, क्योंकि एग्जाम में फिर वो एग्जामिनर उधर लेके जाएगा, वो पेशेंट जो डायग्नोसिस रहेगा दूसरी तरफ पोस्ट वॉल पे डिस्कशन चलता रहेगा.
Yeah, but in this
क्लियर
patient,
बोल
now,
दिया तो चल जाना है.
yeah, we were not able to extract much. He just said that some endoscopy was done. So we presume that, it may be that is why we have written it down. He said that 1 to 2 days the catheter was kept.
So
They
one
don't remember
ultrasound
anything.
history done was there was no oligohydramnios on antenatal ultrasound.
Yeah.
The interesting thing is that he has no lower urinary tract symptoms, but he still underwent a BNI.
Correct. See, many a times what happens that since birth, patient has got flow which is not obstruct. I mean, it is obstructed, but for him it appears that it is normal. So when we ask them the question, they said no, everything is fine. So when we do sonography or when we do uroflowmetry, and we find out something, and then we patient undergoes cystoscopy, and then we do some procedure. So that is also one possibility.
That I agree, but doing a BNI in a 19-year-old male, so
Yeah.
Without having some clinical symptoms in the past, surprising.
So Sharma sir, you want to ask anything? You want to suggest any extra to the
For
students?
me, if I am looking at this patient, I would dig out a lot of his history because this is very perplexing. A 19-year-old undergoing BNI at the age of about 4 months back. So what were his symptoms? But I think whatever has been described by the residents is fine. That's enough.
Yeah.
And if he's not giving any history, he says he's fine, so that's okay. We investigate him further.
Fine. Okay. So Achin, now next what you want to do?
I would like 4 months back record, if we can retrieve it would be better, sir. When the BNI was done, what were the cystoscopic findings? Apart from that, sir, we have to investigate, we have to evaluate further, sir. I would like to do routine micro urine culture and
No examination. You don't want
You
to
will get
examine?
examined. Yeah.
Yes,
General
sir,
examination, systemic examination.
Yes, first examination.
So Ajinkya, what are the important things you are expecting?
So on general examination, like to see for the features of any renal failure like edema, facial puffiness. Then I like to examine spine examination also in this patient.
Why spine?
So he has bilateral flank pain and the history what he is giving is 2 or 3 times he's been operated. Could be a neurogenic bladder resulting into all these symptoms.
So you think that this bilateral loin pain may be because of the spine rather than, or it can be because of some psoas problem. That is what you are suspecting.
Could be.
Okay. And local examination.
So local examination, I like to look for if there is any phimosis, meatus stenosis, palpate the urethra, then focus neurological examination, and then the rectal examination.
Okay, Swastik, go ahead. Swastik.
Yes, sir. So patient examined will lit room with a proper consent and in proper informed consent. Patient was conscious, cooperative, well oriented, time, place, and person. Pulse was 80 beats per minute. BP was 110 by 70 millimeters of mercury. Respirator 18. He was afebrile at the time of examination. Saturation was 99% room air. There was no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Spine examination and head to toe examination were normals. Coming to per-abdomen examination, on inspection, abdomen is flat, umbilicus was centrally placed and inverted. Normal abdominal thoracic respiration was there. There was no scar, sinus, or dilated veins. No visible swelling was there. No visible peristalsis or pulsations were seen. Hernia sites were normal, and external genitalia was circumscribed, and meatus was normal. Bilateral testicle were present. On palpation, on per-abdomen palpation, the temperature is normal. There is no tenderness. No palpable lump was there. Hernia orifices, there was no cuff on impulse, no impulse on cuffing. Sorry, sir. External genitalia was normal, and spine deformity or tenderness was not there. On percussion, tympanic node was heard all over the abdomen, except and adequate liver dullness was there. On auscultation, no bruit, and bowel sounds are normal. On digital rectal examination, no fissure, no fistula or hemorrhoids. Prostate was normal. Prostatic fossa was flat. No nodule was there. Mucosa was mobile, and no blood on fingers. On cardiovascular examination, S1 S2 were normal, and chest on chest examination, bilateral air entry was equal. So no positive.
So Ajinkya, now this is the thing. Now what you want to do? Or you
So like
want
to go ahead with yes, sir.
now, Dr. G.R. Sharma, can we ask them now, can they come to a conclusion that what are the possibilities in their mind? Probable
Definitely, sir.
differential
The
diagnosis?
probability, definitely.
So Ajinkya, now can you just tell us 4 or 5 important, don't tell us, all the probable diagnosis given in the book. Practically, you just tell us what you think.
It could be bilateral circulatory reflux. Could be stricture urethra because of repeated cystoscopies, DNA done. Then
Yeah. The basic complaint was loin pain, left
bilateral
more than
flight.
right, with fever with chills. So the first possibility will always be high will be infection.
Yes.
Now, what has caused this infection, whether it is associated with stricture or reflux or a bad bladder or something, is the secondary thing to look at. But if you are asked what is the probability, what has caused this, if you correlate the chief complaints with his history, This is what I would look at it.
Yes.
So you understand, Dr. Jaya Sharma is saying
Yes, sir.
that first thing is now this patient has developed bilateral probable, pyelonephritis or urinary tract infection secondary to 1, 2,
Other
3, 4. So it can be bilateral renal calculi, or it can be some congenital because he has undergone posterior valve. So there can be associated congenital anomaly, or it can be secondary to stricture or obstruction. Understood? That is what his approach
sir.
is.
Yes.
Fine. Okay, so now what do you want to do?
Like to go ahead with investigation, sir. Routine blood investigation with serum creatinine, urine routine, microscopy and urine culture. And also like to get an ultrasound, sir. UGQB. UGQB WPLS.
Okay, anything else you want to add in this case?
I think Euroflow. He has
Euroflow,
undergone a
yes.
BNI 4 months back.
Yes.
See, he has undergone posterior valve, means some urethral instrumentation twice.
Instrumentation is done. Yes.
Then you will like to do something. No?
Yeah, yeah.
Okay, fine. Swastik, show him whatever he has asked for.
So on examinations, on labs, hemoglobin is 11 grams per deciliter. Total counts are 8,000 per deciliter.
This
And
count
creatinine
is
count
after
2.1 lakh.
this count is after antibiotics, correct?
Yes. Yes.
Yes. After 7 days of antibiotics. And creatinine was 1.2, sir.
Okay.
Going ahead, sir.
Hmm.
Sir, this was the urine culture which was sent initially, sir. Sorry, urine routine microscopy, sir. There was no RBCs in the scene. WBCs were 0 to 1 per high power field, sir, in this. And so the report, sir. Urine culture showed no growth. And this was the uroflowmetry. Voided volume was 256 ml. Maximum flow rate was 14. And voiding time was 25 seconds. And time to maximum flow was 10 seconds, sir. Going ahead, sir, ultrasonography was done. And it showed bilateral hydronephrosis, diffuse urinary bladder wall thickening, query cystitis to be ruled out, and insignificant PVR. Pre-void was 113 cc and post-void was 10 cc, sir. There was markedly parenchymal thinning on the right side, right kidney. Should I go ahead, sir?
Ajinkya, what is the
Yes,
okay? What is the conclusion that you have drawn?
So rule out the stone disease which is causing the infection here.
यार
Could
अभी
be
stone
the
क्यों बोलते हो?
नहीं मतलब rule out. And
I Ajinkya, don't
Yes,
take
sir.
it otherwise. I sometimes am surprised. Stone disease is probably 1/10 of the total volume of all the 3 volumes of Campbell's Urology, but we all keep on thinking only about stone disease. इस patient में तो stone disease is a very late possibility, isn't it?
Yes,
तो
sir.
क्या लगता है? चलो मैं तुमको ऐसे पूछता हूँ. Do you think he has got a stricture?
Sir, Euroflow is showing the U max of around 14, but the Euroflow pattern is not of box type or the stricture type.
Okay. Do you think he has got reflux?
Could be, sir, possibly.
Swastik, don't show.
If I am given only this information, because I have worked for long at a place where we did not have many facilities available, I would think the basic pathology lies with the bladder. Something is grossly wrong with his bladder.
Yes, sir.
the way his flow pattern is, the very fact that there is bilateral hydroureteronephrosis, and the fact that he is carrying insignificant amount of residual urine. Still, bilateral hydroureteronephrosis with large residual urine is very easy to understand. But the fact that he is having bilateral hydroureteronephrosis, but residual volume is only 10 ml suggests that the bladder is not at all good. Yeah.
Fine. So now next, what you want to do? Ajinkya, you want to do scoping
Yes, sir.
or you want to do some investigation?
I'd like to get the VCUG, sir, for this patient.
So why do you
if
want
all
to get a VCOG?
The patient has bilateral hydroureteronephrosis.
So
Like to check for the reflux if present.
right, he is 19-year-old. अगर reflux रहा तो क्या करोगे?
Function, I'll go ahead with the function mode if there is reflux.
Okay. And then, okay, now I will tell you, there is bilateral grade 2 reflux. Then you will get a DMSA scan done. Right?
Yes, sir.
Right. कब करोगे DMSA scan? After 4 weeks, 6 weeks, 8 weeks, 12 weeks. चलो जब भी किया, left side is showing 46% function, right side is showing 54% function, photopenic area seen on both sides. What next?
Function is bilaterally good. Grade 2 reflux. Manage conservatively, sir.
Right. What will you do for conservative management?
Keep him on antibiotic prophylaxis.
Gite sir, is antibiotic prophylaxis a norm in a patient who is 19-year-old? Ajinkya, see, what I am trying to tell you is, this is I mentioned to you initially also, कि bilateral hydroureteronephrosis and no residual volume means bladder is at fault. So if I am asked which investigation I would do, I would ask for a video urodynamics. Ideally speaking. That will help me in number of ways. It will tell me how the bladder is. A good video urodynamics done will give me an idea about the reflux also, if at all we are so keen about it. But this is what I would do first. Gaurang sir, आपका क्या opinion है?
No,
ऐसा है कि people.
Yes, sir. Go ahead.
Usually क्या है कि आप समझो for example sonography. In this patient, sonography will give lot of information. If you try to search it, okay, how much is the post-operative, how much is the bladder capacity, what will be bladder wall thickness, hydronephrosis is right up to the bladder or not, how is the posterior urethra, ये सब चीजें पैरेन्काइम थिकनेस, ये सब चीजें देखना है ना. 2 लाइन पढ़ लिया आगे चले गए तो फिर वो तो रेडियोलॉजिस्ट का तो काम है कोरिलेट क्लिनिकली. अब बार बार अगर सर सस्पेक्ट करके ब्लैडर क्या सोनोग्राफी पे मिलता है. यूरिन रूटीन में 2% बोल रहे हैं, उसके बाद में यूरिन कल्चर.
Yeah, till Dr. Gite comes, when all the facilities, Ajinkya and Achint and Miraj, when all the facilities are available, then whatever Dr. J.R. Sharma is saying, that you can think of doing. But in case of this, we can always, if you don't have facility, you can say, because there is a hydronephrosis, I would like to see the upper tract by an investigation, And at the same time, I will like to rule out whether there is any reflux or not. And what is the status of the bladder?
Sir, sir, there is a history of BNI itself. Why there is a BNI at this young age? So patient definitely must have some neurogenic element like high pressure bladder or dysfunctional voiding. Something is there. ये एज में बीएनआई करने का क्या कारण है? कौन सा ऑब्स्ट्रक्शन ये एज में बीएनआई करने के लिए मजबूर करता है?
Fine.
Definitely it is there some resistance by neurogenic element. और आप तुमको न्यूरो जैसा भी पोस्टियोतल वाल का हिस्ट्री भी है, तो इसमें प्रायोरिटी पे जैसा भी शर्मा सर बोल रहे थे कि वैसा यूरोडायनामिक का इम्पोर्टेंट नहीं है. तुम्हारे पास नहीं है तो तुम जहाँ पे होता है वहां पे भेजना है. मेरे पास नहीं है, ये कोई आंसर नहीं है.
No, but in this case,
नहीं तो
if
डायग्नोसिस
the
नहीं होगा.
बराबर है. But in this case, when the bladder is not showing much circulation, trabeculations, number one, residual urine is not there, and the uroflowmetry is not so much obstructed. So in this condition, considering these three things, and if there is a bilateral hydroureteronephrosis, uh, whether it is must to do urodynamic study, or you can go ahead with the
सर
thing.
हाई प्रेशर ब्लैडर का सेम प्रेजेंटेशन रहता है. हाई प्रेशर ब्लैडर में आप पोस्टल रेसिड्यू ज्यादा रहता ही नहीं.
But there will be
और
circulation and
there will
trabeculation.
be bilateral hydroureteronephrosis. Everything will be normal. Cystoscopy will small capacity thick wall bladder रहता है, इधर उधर थोड़ा सा रेडनेस रहता है. वो प्रेशर की वजह से ऊपर का आइदर ऑब्स्ट्रक्टिव रहो या रिफ्लेक्सिंग रहो, लेकिन that is the one cause for causing the bilateral hydroureteronephrosis.
Okay, so whenever you are, even if you are not suspecting, like, if there is no residual urine, the bladder is not showing circulation, trabeculation, or diabetic color, but in that case, you advise students to do urodynamic study, correct?
Sir, I would put it this way. Somebody
Posterior wall, with this history of posterior wall and DNI, definitely there is of this patient. And
Okay.
patient had bilateral hydroureteronephrosis without obstruction supraoceanic. That means there is something wrong in bladder. Without that,
Fine.
why there is a bilateral hydroureteronephrosis?
Fine. Okay. So in this case, we tell students, okay, if you get such a case, it is always advisable to do video urodynamic study. Fine. So that is the conclusion. Okay, Sasik, what we have done? Okay, so we had done
VCU
VCUG.
was done, and
Yeah.
yes, VCU was done. Only history was done.
So any one of you can comment on this?
I'll
Ajinkya?
comment, sir.
Yeah, okay, Achin, you say.
This is sir, film oblique film, two oblique film on either side of the voiding cystorethogram. It shows smooth line bladder wall with normal posterior urethra with with I can appreciate the shadow of Viromontanum. And sir, there is no viewer in this film. Well, there is no viewer in VCG.
What else?
And posterior urethra is normal, sir. And bladder neck is wide open, sir. It's not. Yes.
Okay. So Sharma sir, now on this, what you advise? Now in this case, we have not done video this thing. It was because we presume that
So we have done an MCU, that's fine. Then the next step would be do a urodynamics.
So after this, we should do urodynamics.
Yes.
Okay. Anyway, because we have not done urodynamic, and we have done yes, Swastik, what we have done?
So we had done a CT scan.
Okay, show them.
CT.
Now in Sharma ji, in this case, whether they should talk about CT scan or they should not talk about CT scan.
I won't say a word about CT scan. My
Anand?
flow would be basic work, lab workup, ultrasound, based on ultrasound findings, video urodynamics. If not video urodynamics, MCO has been done, which we have seen. Next step would be urodynamics. I won't do a CT scan at all.
Okay. Fine.
Well,
So
and
then,
if the student has told they will do a CT scan, then they have to defend the CT scan. क्योंकि ये केस में until and otherwise there is some clue towards the supravasaic obstruction or to assess the function indirectly. As such, there is directly no any role of CT scan. I agree with Sharma.
no, but whenever there is a bilateral hydronephrosis, hydroureter, and in this VCUG, I think bladder was not showing any signs of severe trabeculation or even diverticuli. So
That is
can't be
more the reason why to do a urodynamics.
Agreed, sir.
Okay, so we have in this case the urodynamic is not done, so that is a missed thing, and we have done this CT scan. So
Sir,
okay, after this,
if a urodynamics is done, the report would be slightly decreased capacity, decreased compliance, no detrusor overactivity, normal sensation, and good contractility of the bladder, but poor flow rate. The contractility will not be more than 50 to 70 centimeter of water. This is what I would presume looking at his overall picture now. But it will definitely show a decreased compliance.
okay, now we have got this picture, CT scan.
Should I read CT scan?
Yeah, you read it.
This is the contrast film of the CT abdomen pelvis with the solid organ appear normal. Uh, uh, Solid organ, namely liver and spleen, appear normal, and there is gross hydronephrosis with hydroureterosis of both the kidneys with significant parenchymal thinning of the right kidney, also the left kidney, but right more than left, and there is no obvious calculi seen, sir, and bladder is smooth walled. This much.
Okay, so Dr. J.R. Sharma, is there any role of CT scan in this case, or there is no role?
Role, sir, according to me. A good ultrasound will give me exactly the same amount of information. Now, sir, see, how I look at it is, we need to find out, one, we know the presentation, the fever is on account of probably UTI, he is under cover of antibiotics, hence the counts are normal and the urine examination is normal. Now, why does he have a abnormal flow pattern? What is the genesis of the symptoms? What has happened in the past is difficult to know, and I personally don't think he ever had a PU valve. He has some bladder pathology. The bladder is not functioning well, and this is resulting in poor drainage of the upper tracts. So we will have to look at the bladder function dominantly. Later on, if we want to actually just objectify what is the functional status of the kidney, then a sort of a renogram, DMSA or something would be good enough. But the pathology lies with the bladder, and the way to diagnose it would be a urodynamics. And then subsequently, if at all there is a reason, if it could be a neurogenic cause, which is again, I feel very unlikely. It is more likely to be a dysfunctional voiding. at the age of 7 years, the child continued to have some voiding difficulty, hence he probably underwent a cystoscopy. Because nothing would have been found, a catheter must have been put for 1 or 2 days, which is a very routine thing. After that, he continued to have these voiding dysfunction. But as Gaurang sir had initially said, that sometimes they get used to it. But when it became a bit more, because now he's 19 years old and his friends must have realized that he's probably taking a much longer time to pass urine as compared to others. That must have brought to his notice that something is wrong with him. He might have gone, flow rates must have been done. It would have shown that it's a poor flow rate, and there is bilateral hydroureteronephrosis with some large residual urine that time, and hence he underwent a bladder neck incision, which at 19 years is again very unusual. And following which, because the bladder is still not addressed to, he has developed infection. This is what I would summarize looking at the data which is available to me at present. Gite sir, your comments?
I am
Maheshwari,
agreeing with you, sir.
Maheshwari has joined.
Whatever you have said, that may be the probable pathway till time with this patient.
So now, in that case, we don't want to address the upper tract when there is a hydronephrosis and hydroureter.
No, sir. Issue here is why there is hydronephrosis and hydroureter. So first we have to address the pathology.
No, cannot be there bilateral primary, like, ureteric obstruction, megaureter. That possibility never exists.
Sir, is
We are,
there a
we are not telling like that that there is a bilateral. That's what I initially told, sir. Ki supravesical obstruction, bladder, and infravesical. So there are three reasons where there is a bilateral hydroureteronephrosis. Here, considering the history, the main target is bladder. Until and otherwise, someone prove that the bladder is normal, and any on sonography there are no stones or the hydronephrosis is right up to the bladder. Okay, and patient had a wide BNI का history है, यूरोफ्लोमेट्री नॉर्मल है, पोस्ट वाइड नॉर्मल है, तो इंफ्रावेसिकल का कोई चांस नहीं, जो भी है वो ब्लैडर रिलेटेड है. अभी आप पूछ रहे ये जंक्चर पे कि सुप्रावेसिकल कुछ कंजेनाइटल रह सकता है क्या? तो अगर रह सकता है, रह सकता नहीं है ऐसा मैं नहीं बोल रहा हूँ. बायलैटरल यूरेट्रिक समझो, बायलैटरल यूरेट्रिक स्ट्रक्चर डिलेड प्रेजेंट होगा, बायलैटरल यूरेट्रिक वॉल वेरी वेरी रेयर पर हो सकता है. बायलैटरल एक्टोपिक यूरेटर हो सकता है, बायलैटरल प्राइमरी ऑब्स्ट्रक्टिव मेगा यूरेटर हो सकता है. ये सब चीजें पॉसिबिलिटीज है, नहीं ऐसा नहीं है. लेकिन अगर वो सब बायलैटरल ऑब्स्ट्रक्टिव चीजें है तो ब्लैडर में यूरिन कहाँ से आ रहा है, वो ड्रेन कहाँ से हो रहा है, उसका यूरोफ्लोमेट्री कहाँ से नॉर्मल आ रहा है, दैट मींस दैट इज इनकम्प्लीट ऑब्स्ट्रक्शन है. ये सब चीजें ब्लैडर का जब तक कोई प्रॉब्लम सॉल्व आउट नहीं होगा तब तक उसको प्राइमरीली मैं नहीं देखूंगा कि ऐसा कुछ हो सकता है.
Okay. Fine. So now, considering this case where the urodynamic is not done and this is a picture, you are recommending that we should not go ahead without doing urodynamic study.
Yes, sir.
Okay, fine. So that is the conclusion. Anyway, so let us go ahead. Swastik, what else? Okay, Achin.
Yes.
Yeah. Miraj, you want to say something?
Sir, is there any proximal ureteric stricture also in this, in bilateral? Narrow
No,
segments.
there is a tortuosity, but
Uh,
apart from that, there is obstruction just at
Proximal
the.
ureters, both are very narrowed compared to the rest of the ureters.
Yeah, but
Cannot
lower
diagnose
ureter is
stricture
also
based on
dilated, no? So
disease.
that is because of the kink.
Okay.
See, Miraj, if
So it's
there
a
would be a
static image of a
stricture,
dynamic study.
how come so much of contrast would have dropped down?
Yes, it's draining. Yes.
It is draining.
Yes.
देखो, majority times these are the secondary of having a secondary of these are the kinks, and majority times these are not non-obstructive in literature wise also. It usually drains. Until and otherwise it will cause a secondary obstruction. Then the distal to that, there should not be any drainage. And if there is, as here on both sides, the bladder is getting drained and both kidneys are draining inside the bladder. So these kinks are usually a non-obstructive.
Okay.
Okay, fine. So, Sachin, now next, what we have not done urodynamic study, we have not proved whether it is the bladder problem which has caused all these things, but we have just done this CT scan and we have seen bilateral hydronephrosis and hydroureted with the tortuous ureter. So now next, what you want to do?
Next, sir, I would like to do urodynamic.
No,
VD
urodynamic is not done. We have done it.
Now, sir, in CT, it's quite visible. There is marked thinning of the right renal parenchyma, right more than left. So, I would like to assess the function of this kidney. I would like to go ahead with renal scan, DTPA scans.
Okay. Fine. Just show what we have done. Swastik.
Yes, sir. DTP scan was done, sir. Yes, sir. DTP scan was done, sir. It showed 54.33 ml per minute GFR from the left kidney and 17.29 ml, that is 24% of the total GFR from the right kidney, sir.
Fine. Anything else is there?
So on the right side, radio tracer uptake was slow and sluggish, and tracer clearance from the pelvic system was delayed on static imaging. And left side kidney appeared normal in size, and there was mild hydronephrosis, and it showed preserved perfusion and parenchymal radio tracer uptake with non-obstructive tracer clearance from the pelvic system on delayed static imaging. So,
do you trust this renogram?
Pardon?
Do you trust this renogram?
So considering the pathology in bladder, this renogram.
There is one thing very odd about it. Achintya had read the CT scan and he said markedly dilated, enlarged right kidney. And this renogram mentions right kidney is small sized. So the region of interest drawn on renogram must have been erroneous, which results in an erroneous differential function.
Yes, sir.
Gaurang sir, आपको क्या लगता है?
Yeah, no, I am putting this case for whatever has been done. I am just showing it. It is you and Dr. Gite who has to find out where the something has been missed or where something has gone wrong.
Ajinkya, we need to realize that the function what is obtained is based a lot on the region of interest which is drawn. There are a lot of errors which can come in when renogram is being done. And this is, I think, one example, because if you look at the CT scan, the right kidney is really markedly enlarged, and he is mentioning that the right kidney is small. So the region of interest drawn ROI must have been small, resulting in a function which is 24%.
Yes.
Fine. So, Swastik, now the first thing is that urodynamic study is not done. That is the one thing. So that is the one thing which we have missed. You are supposed to say in the exam, and this case might lead you in a different way. But we have not done it, and we have done it in a different way. So, okay. Swastik, what else? What was done in this case?
sir, then we had the plans, sir.
No,
This
yes.
was the all investigation that we did.
No. Before that, what we did? Don't go there. This is the second. After that, what we? Yeah. So I'll tell you what we did. Which we presume that there is a bilateral obstructive megaureter because the flow was not poor. This is my presumption. And it is a very tortuous ureter. And when we did cystoscopy, we found out that definitely the bladder was not so, severely tabaculated or anything. and we thought it is a bilateral obstructive megaureter. And we went ahead with the bilateral, one after another, reimplantation of ureter. This is what we have done. This is a presumption, and we have done. And of course, when we operated, definitely there was the primary megaureter. There was a lower end which was quite narrow compared to after it was entering into the bladder. So we did the straightening of the lower ureter and also tapering, and did the surgery, the implantation ureter. So after that, patient was apparently all right, and then he started getting fever. So yeah, you can just tell them what to do in such cases, right or wrong, whatever it is.
I wouldn't have thought of a ureteric reimplant. I would have done a urodynamics and stabilized his bladder, because still his flow and everything. And of course, I would have, I cannot think of anything doing any intervention without a urodynamics in this case.
Okay. Fine.
And now when he has started, now suppose let's assume that he has come after getting all this thing done. So now my interest would be to see how much is the residual urine and how the flow rate is. Because all said and done, even if it is done one after the other, there is a possibility that he may have a large residual volume. So that needs to be ruled out. He should be kept on antibiotics. And now again, we are back to square one, get a urodynamics done again.
Okay. So that is the thing, that urodynamics should have been done. Fine. So let us now go ahead with this case, how to go about. Whatever has been done, has been done. Correct? Okay, Swastik, go ahead. What happened next?
Yes, sir. So following ureteric implantation, patient developed tenderness fever for 2 days. After 2 days of the surgery, second reimplantation, patient was started on empirical antibiotics, and then culture sensitivity was also sent before the starting antibiotics. Antibiotics, according to sensitivity, were then started, sir. And the urine routine and culture sensitivity were these, sir. This was urine routine, and culture sensitivity showed Klebsiella pneumonia and pneumonia that was sensitive to ceftazidime avibactam combination. We then did a sonography. We showed a pre-ward volume of 217 cc, post-ward 24 cc. Both kidneys were still bulky in size. Bilateral gross hydronephrosis was seen with paper thinning of the renal parenchyma, and proximal ureters appeared dilated, and mid to distal ureters could not be evaluated due to excessive bowel gases. So the findings were suggestive of bilateral gross hydronephrosis with paper thinning of renal parenchyma. Proximal ureters were dilated. Following this, a plain CT scan was done, as create was around 1.5 at this point of examination. This showed a
Basically, we
moderate.
wanted to,
Both the
I'll
kidneys
tell
were
you, because the patient was getting continuous fever, we wanted to just rule out that we are not missing any collection or any pyelonephritis, severe or pyelonephrosis, because already bilateral reimplantation was done. Earlier, patient had fever, which had come under control. WBC count was normal, pus cells were not present, culture was negative, and again, patient started getting fever, not responding to most of the treatment. So that is why we did all these things, but it showed the same thing, residual hydronephrosis, little hydro, that the same hydroureter. This is a thing. So Achin, now this is a story. Now what you'll do then?
Gaurang sir, एक out of the box question.
Yeah.
I just want to know, these two ultrasounds have been done by two different persons.
Correct.
Is it possible that the first ultrasound was done by a pretty senior person and the second was done by somebody who is not that senior?
Maybe possible, because the first was done some better place. This was after admission in a small hospital it was done. So probably I have not gone into the details, but I can find out.
Yeah,
Yeah, yes, what you are saying is right. Because this is not like, at one place. We are operating at multiple places, so depending
right.
upon the. So what you are saying is right. Yes, there is a possibility.
Yeah.
See, the idea is that unless and until we keep the full case with a complication, the students will not get the right approach to the case.
Very true, sir.
So now whatever has been done at the end of this full case, I want students to get the right approach, because they are not going to come across such cases every now and then. So when they start practicing or they are answering in the exam, they are well prepared in their mind that what they will say and what they will do.
Very correct.
Okay, fine. So the story is that patient's infection is still there, means he is getting fever, continuous fever. With 14 injections, he improved. Again, after 10-15 days, he came back. So totally, after this surgery, almost 1 month had passed and still patient had a recurrent fever. So Achin, now next what you will do? So we removed the digestan. In between, before this CT scan, we had removed the digestan, thinking that patient has got infection because of the foreign body. So we removed the digestan. Now this is the story. This is the CT scan after that. Achin, now what you will do? Ajinkya, can you tell us? You understood? We have not done urodynamic study.
Yes, sir.
Presuming this is not a neurogenic bladder and primary megaureter, bilateral reimplantation of ureter was done. Patient has infection, okay, recurrent infection continuously. Even the highest antibiotic was given, improved for 14-15 days, again developed fever. We thought that it can be secondary to foreign body, so we removed digestan. CT scan was done after this. This is a report after the digestan removal. And next, patient still has fever. Now what you'll do?
Can I answer?
Ajinkya? Yeah, Ajinkya, tell us. Achin, tell us.
Since it's still showing gross hydronephrosis on both sides, sir, and patient is not responding to even higher antibiotics, temporary urinary diversion has to be done. It could be done in the form of again degestanting or bilateral PCN insertion, sir. Or when we are doing bilateral PCN insertion, we can try anterior grade stenting also, if possible.
Okay.
Again, Achin, bladder is not getting addressed. Either you have to say some add CSIC or have a indwelling catheter till the infection settles.
Yes.
Yeah, we had kept the catheter also, thinking that he is not emptying his bladder. So that also was kept, but fever was not coming under control. And the output had not increased. It was same.
Yes.
So Achin, what you will do now? You said, na? So we did a cystoscopy. We could not see edema was there around the ureter or anastomosis. So we could not negotiate it. So we did bilateral PCN.
Yes.
Fine. Okay. Swastik, can you show them? Do you have that photograph? There's only one side. As you can see,
So this
the
was the
torches.
Yes, only one.
He has not got other photographs, but probably, and this is a ureter which is not so tortuous as per earlier CT scan, because it has been straightened. The thing was that it was going right up to the bladder. After that, the dye was not entering into the bladder. So we kept the nephrostomy on both the side for almost 2 to 3 weeks, and we tried to do antegrade degescenting, but it was getting blocked at the ureterovesical junction. So now this is the story. So Achin, up to this much we have done. Now next, what you will do?
Next, I would like to do urodynamics.
Okay. So now when the patient will come, we will do urodynamic study. But we'll have to address this. We have already done anastomosis. G.R. Sharma, your suggestion now. I have done up to here. Now what to do?
Sir, see, if urodynamics, now let us assume he is at a place जहाँ से nearest urodynamic facility 400 किलोमीटर
No,
दूर
no,
है.
he will come here and I will do the urodynamic. That is one thing.
नहीं, but अगर वो नहीं है, तो
हाँ.
I would put him on bladder relaxants. I would put him on bladder relaxants if urodynamics is not there and put in a catheter. His infection has to settle down, and then only anything is possible.
Okay. So
At this particular
no problem.
point, the
We will
presence of
do.
infection, even urodynamics would be fallacious.
Right. So we will do that. We will put him on a catheter. We already had done that. And the infection was totally, now he is absolutely, he has no infection. matlab, He has no fever and WBC count. Everything is fine. It had gone up to 30,000 and now everything is fine. Okay. So that is the story. Now I have called him after 1 month. So after 1 month, you again want me to put the catheter if he has no fever and no.
No infection, no fever, urodynamics,
Okay. After urodynamic,
whatever it is.
no, because this is, see, now the scenario is little different. Now we have already operated him.
If contrast is not going inside the bladder by antegrade pyelography on both sides through PCN, that means there is either obstruction on both sides at the site at the level at the site of surgery, or after treating the bladder and doing the urodynamic, if that urodynamic doesn't have high pressure bladder, then that obstruction should be addressed. So how you will someone address the obstruction? The redo surgery या दूसरे उसके सिवा दूसरा कोई चारा नहीं, लेकिन प्रोवाइडेड दैट उसके पहले ब्लैडर का जो भी है वो सॉर्ट आउट करना जरूरी, क्योंकि कॉन्ट्रास्ट नीचे नहीं आ रहा है, इसका मतलब वहां पे प्रॉब्लम है और वो पोस्ट सर्जरी दोनों साइड पे अगर ब्लॉक बन रहा है तो उसका सर्जरी जरूरत पड़े तो रीडू सर्जरी करना पड़ेगा, प्रोवाइडेड दैट ब्लैडर शुड बी एड्रेस्ड फर्स्ट.
Fine. So all the students, now when such a situation there are now 3 things you are supposed to do. Number 1, wait for some time, let the infection, edema, everything settle down. Do urine routine again, culture and sensitivity, post-word residual urine. If you want, you can also put the catheter and drain bladder. Start, as Dr. Sharma has said, the bladder relaxant. Once everything is okay, you do urodynamic study. Now, whatever, as Dr. Gite has said, if by doing this nephrostogram, if the dye is not going down into the bladder, we have to address this obstruction. But if the dye is going down, then again, depending on the urodynamic study, we will decide regarding the redo surgery. Correct? Sharma,
Yes,
am I
sir.
right?
Perfect, sir.
Fine. So this is a story. Now this patient will come back. I will just put it on a group what has been done. Okay. So the students, the message is that whatever the story may be, you must do urodynamic study.
Sir, one doubt, sir.
Yeah. Achin, tell us.
Sir, I want to ask one question, sir. In this case, sir, up till we have done the VCUG, a 19-year-old male with no lower urinary tract symptoms, with a near normal uroflowmetry, with normal bladder in USG with non-significant pre-void with near normal uroflowmetry. Still neurogenic bladder doubt has to be there.
उसको नियर नॉर्मल यूरोफ्लोमेट्री है ही नहीं, उसका ब्लैडर नेक इंसिजन हुआ है 4 महीना पहले. So that is the biggest stumbling block in the entire thing. यानी if you want to diagnose it as a congenital megaureter, why should somebody undergo a bladder neck incision at the age of 19 years? And that uroflowmetry is definitely not normal. 19-year-old.
Many.
So my question is like patient already has given
देखो
enough
whatever the findings you are telling is post BNI.
Yes.
Yes, sir. Yes.
So that will answer your question.
Agreed.
But sir, posterior wall, sometimes we do get of case of bladder neck hypertrophy in which BNI can be done. So all the bladder pathology can be attributed to the hypertrophied bladder neck. So
Very right. Very right. But in that scenario, you would have a markedly trabeculated bladder. And either if the trabeculated bladder is not there, he would have had bilateral massive reflux. ये दो
So,
चीज
Achin,
नहीं है
my
तो ये
counter-
PU valve पड़ता ही नहीं है.
Achin, my counter question to you: in posterior urethral valve, don't you have bladder syndrome later on in life?
yes, sir, but VCG is normal.
That
sir.
means
There is no
bladder dysfunction persists, right? I'll tell you one very crude way which I learned when I was studying, that in all pediatric urology, mostly all pediatric urology cases, you will never be wrong if you say UDS and CSIs. Sorry about this. It's a crude way of teaching, but I'm telling you, most of the times it's right. In this case also, CSIC will be one of the options which will become his end treatment.
No, CIC because that doesn't have any residual urine. So CIC is not going to be of a great help. But as the
High
doctor,
bladder volume, high pressure may be there, sir. High voiding pressures.
but then again, CIC you are going to do 4 hourly or 6 hourly. So it's continuous drainage by the catheter, maybe to some extent.
Achin, whenever such case come in exam, think simply why there is bilateral hydronephrosis. Simple. First question. It is either supravesical, vesical, infravesical. So infravesical BNI has the uroflowmetry is normal, postpart is nil. So infravesical at present no any acute which needs attention. Next is bladder. Uska next is supravesical. So supravesical is draining or not draining? So it is draining inside the bladder. So that also doesn't require active at present intervention. So remaining is bladder. So why that bilateral hydronephrosis has occurred? So either it should be secondary to that bilateral bladder neck stenosis or hypertrophied bladder neck, which is a residual one, or bladder problem. इन्वेस्टिगेशन 4-5 ही है, उसके बाहर कुछ भी नहीं है. ब्लैडर के लिए यूरोडायनामिक है, नीचे के लिए एक आरयूजी एंड एक एमसीयूजी है, ऊपर के लिए एक डीटीपीएन सीटी स्कैन है. कार्यक्रम खत्म हो गया. इसमें ही दिमाग लगाना है.
Okay, now little before we close down, this next time we have got a very nice case. GR Sharma, we want you to be there. In this, just let us ask few questions about the anomalies only. So, Achin, what are the ureteric anomalies? How will you classify?
ureteric anomalies, sir, from top to bottom, I'll start, sir. It could be bifid pelvis. It could be partial duplication of ureter. It could be complete duplication of ureter. And these duplication of ureter with single opening or double opening. And it could be ureterocele. It could be an ectopic ureter. It could be these many. It could be congenital mega-ureter, sir. These many.
So what is Wegat-Mayer law?
Wegat-Mayer law stands for, sir, complete duplication of the ureter, in which the upper meaty ureter opens infero-medially to the normal location and is more prone for obstruction, and the lower moiety ureter opens superolaterally and is more prone for reflux.
So which are the places where you can get the ectopic ureter?
Ectopic ureter, sir, in males it could be, apart from the normal trigonal area, could be supratrigonal, it could be infratrigonal, it could be bladder neck, it could be prostatic urethra, but proximal, it could be perineum, but proximal to the external uterine sphincter. In females, it could all the above places and also vagina.
What about prostate or seminal vesicle?
Yes, sir. Yeah, seminal vesicle, prostate also, and prostatic urethra also. Yes. Perineum also.
So in which condition you will get reflux as well as the PU junction?
Well, sir is asking about PUJ with VUR.
It could be in duplication of pelvis, sir. In the VUR is of the lower moiety, and UJ could occur in isolation anywhere, sir.
Gite sir, you can just explain him.
Congenitally, PUJ with VUR is possible, na? What is the percentage of association PUJ, case of PUJ associated with VUR, or what is the percentage of VUR associated with PUJ?
10 to 15%. 10 to 15.
What 10 to 15?
In mega ureter with PUJ could be possible, sir.
To say PUJ obstruction is associated with reflux in about 10 to 40% of cases. But I will tell you now, Ajinkya, the behind it. This is based on the data which was there for elderly children, not prenatally detected hydronephrosis. When you talk in terms of prenatally detected hydronephrosis, the figures are different. And the management is also different. Okay, one last question. Suppose there is grade 5 reflux and there is PUJ obstruction also. Which one will you operate first?
PUJ first.
Right. Why?
To tackle the PUJ first, and later on keep it refluxing, and then later on we can deal with the refluxing.
And you will never operate both the things at the same time.
Yes.
Why? What you are going to do for a PUJ? What type of?
Why
may settle
PUJ and robotic reimplantation at VUJ? So there is no discussion on both sides. Sir, Sharma sir.
Yes, sir.
So well done. Ideally, no one should do both the things in one sitting, but आजकल क्या है वो सब मिनिमल इन्वेजिव के चक्कर में वो रोबोटिक रिइम्प्लांटेशन विदाउट कटिंग जस्ट मेकिंग द टनल एंड प्लेसिंग इनसाइड द ब्लैडर
I have
आइडियली नहीं करना चाहिए.
sir, very early in my career, I had two such patients जो किसी ने किए थे PUJ और UVJ both at the same time. UVJ just dropped down, but वो stricture होके इतना जान खाया है.
Yeah, so you
सही.
explain them. Both the side we
Yeah,
are going
so
to
see,
cut totally. So
yeah,
the blood
instead of
supply is
doing-
going to be affected. Understood, Ajinkya?
Yes.
You are going to do anthracene, yeah?
You cannot
Yes, sir.
disconnect the ureter at both two sides.
Understood. So that
it's
is
the
why you
same
should not.
principle कि अगर किसी को hypospadias है तो आप transaction anastomosis नहीं करते.
That is one of the indication for non-transecting uretroplasty.
Non-transecting urethroplasty. Right.
So what is opposite means Vegard-Mayer law है ऐसा corollary or opposite to that? Ajinkya, can you answer?
Not a whole, sir.
Achin,
क्या सर क्वेश्चन?
what is a Vegard-Mayer law and what is opposite to that? When it is means in which condition you will not get it, or what is the name of that condition?
There are few exceptions to the Weigert-Mayer law in which even in the total duplication of the ureter, the destined, as per the Weigert-Mayer law, the destined openings are not at the place, and apart from that, there is one
Ectopic
known
law,
as
sir.
Stephen's ureter.
Stephen's ectopic.
What is the name?
Stephen's pathway.
Stephen's
Stephen?
ectopic.
Ajinkya, you know it? Name?
Stephen's ectopic.
Pathway.
Okay. Sharma ji, आपको if you, I just remember this Stephen. Do you have any information about that?
Anatomical exceptions, sir.
The anatomical, according to what I remember, the exception to Weigert-Mayer law is कि अगर normally the upper moiety will drain down lower and will be obstructed most of the times, and the lower one is more laterally placed and is associated with reflux. If it's a triple ureter, then this law doesn't hold.
As we are discussing a mega ureter today, there are few quick questions examiner may ask, like what is a normal caliber of ureter? Then what is meant by mega ureter? Previously, how much more than how much millimeter or centimeter is called as mega ureter? Now, how much millimeter or centimeter is called as mega ureter? What are the causes of mega ureter? Then in which cases you will do just application? In which cases you will do excision and tailoring? Then what are the types of tailoring? Then what are the ways of doing the reimplantation? Then how will you follow the patient of mega ureter? Then how will you assess the functional assessment in case of mega ureter? And in how will you diagnose the mega ureter? So these are
The most
some
difficult
quick
question: how will you
questions.
diagnose an obstructed mega ureter?
Exactly. So here, which film you will take? The bladder should be full or empty. ये सब चीजें वहां पे आती है. सीटी आईवीपी करना है या कन्वेंशनल आईवीपी करना है तो ब्लैडर फुल रहेगा तो उसके पीछे चला जाएगा, दिखेगा नहीं है. ब्लैडर एम्प्टी करके देखना है. या सीटी आईवीपी भी कर रहे हो तो वो पर्टिकुलर फेज लैटरल फिल्म लेना है, ब्लैडर एम्प्टी रहना है. ये सब चीजें मायने रखते हैं. छोटी छोटी चीजों के ऊपर तुम प्रैक्टिकली काम किए है कि नहीं है ये उसमें पता चलता है.
Fine. So next time also we have got one Bachu, like the similar case. So whatever is remaining, we'll discuss next time. This case is also next case is also very interesting case. It's not a straightforward. Sharma sir, आपको हम बोल देंगे कभी है, हाँ?
Yes, sir.
Next time, Swastik. Because again, this is going to take about 1.5
Okay, sir.
hours. And we want Dr.
Yes, sir.
Sharma to and Dr. Gite to And please, this next time again inform Dr. Maheshwari well in advance.
नहीं सर थे सर आज पर कंटिन्यूसली ही इज लिसनिंग इन बिट मेरे ख्याल से कुछ काम हो गया पता नहीं कुछ बिजी होंगे
सर वो ऐसा है कि पीएम लास्ट में ही स्पीच देते हैं।
नहीं जस्ट शायद लीव कर दिए कि है पता नहीं
ओके ओके
चलेगा सर। अभी तो उनकी टांग खींचने दो।
नहीं शायद
Okay.
जस्ट लेफ्ट हो गए इसलिए बोल रहा हूँ थोड़ा पहले बोलते तो जम जाता था
No problem. So, the lesson learned is very important. I will let you know what we do now, and next time we'll have a new case. Okay.
ओके सर
Thank
थैंक
you
यू
all of you. Thank you very much.
गुड नाइट
Thank you.
Thank
Good
you.
night.
Good night.
Thank you, sir. Good night.